morning, everyone. It is my pleasure to be with you today. My name is Maxime Ronot from Paris, France, and I will be talking about the diagnosis of HCC, about imaging, and beyond that. Now, to understand the context of what I'm going to talk about, we need to remember that HCC is the end stage of a very progressive transforming process that turns regenerative nodules into malignant tumors over different steps of progressive malignant transformation. And during this multi-step process, the tumors will accumulate some changes that we can see on imaging. The most famous one and important one are vascular changes. And we know that from the cirrhotic nodules to the progressed HCC, there will be a progressive accumulation or increase in the number of abnormal arteries, so a relative increase in the arterial flow and a decrease in the portal venous flow. And it translates very well on imaging, and these are the two main imaging features that we know, which is first the arterial phase hyperenhancement that corresponds to these many isolated arteries, and on the right hand side you can see some washout which correspond to the relative decrease in the portal flow. Now, aside from those very famous ones, we can find others like metabolic alteration and especially the accumulation of fat in the early stage of the dysplastic transformation, and also the progressive ability to store iron from the low benign nodules to the very malignant one. And again, this is something that we can see, and we are very aware that modern imaging, and especially magnetic resonance imaging, is capable of showing us the presence of iron and fat, especially using chemical shift sequences. Another change is the architectural modifications with the progressive decrease in the size of the tumor cells, so the cell density will increase, and as a reaction, the surrounding liver will try to encapsulate the nodule, the tumor, and it leads to the progressive appearance of a capsule. And again, this is something we can see. Cellular density can be captured with diffusion weighted imaging, and the capsule is very well depicted, whether or not this is an enhancing capsule. Final one that I think is very important is the progressive loss of the hepatocellular function from the early to the late stage of the hepatocarcinogenesis. And it means that the non-functioning HCC, the abnormal HCC, the malignant HCC, lost their ability to produce and express the features of hepatocellular function. And this is something we can see if we use the liver-specific contrast agents, because we know that these drugs are taken up by functional hepatocytes, and that most malignant tumors will translate into hypointensity on the hepatobiliary phase. Now, very interestingly, this decrease in the function precedes the appearance of arterialization. So during a certain period of time, specific nodules will not show arterial phase hyperenhancement, but they will already show signal hypointensity on hepatobiliary phase. And those hypo nodules are very interesting because they correspond to a group of a mix of HCC, early HCC, and high-grade dysplastic nodules, so very important for patient monitoring and diagnosis. And of course, the larger the tumor is, the more visible it is on T2 and diffusion, and of course, if AFP is elevated, well, this is more favor of HCC. Now, all of these diagnostic features have been combined in a variety of diagnostic systems since the beginning of the 20th century, and I've listed the most important one from different continents. And as you can see, we have many, and many are constantly updated. And one common feature of all these diagnostic systems is the concept of non-invasive diagnosis. It means that if a patient is recognized at high risk of HCC, and if imaging can depict a combination of specific features, well, we can diagnose non-invasively the HCC without the need for pathology. But if the patient is not at high risk, or if the patient does not display all the necessary imaging features, then we need to biopsy. Now, this is one of the things that very, very much is present in the EASL guideline, and the very recent update of this clinical practical guidelines reinforces the strength of the non-invasive diagnosis, but changes a little bit the way it should be done. And the change is based on the endorsement of the LIRAD system, the liver imaging system coming from the American College of Radiology. The aim of this system is not only to diagnose HCC, but also to provide a standardization of definitions, of technology, of the techniques that lexicon definition and all the standardization are very informative for you, and I encourage you to read the documents to improve your knowledge about that. Now, to be fair, we have different LIRAD system. Today we are going to talk about the diagnostic LIRAD system, especially for the CT and MRI, and I'm not going to discuss everything with you. I'm not going to go into details. You know, it's a multi-step process. And the idea is, at the end of the day, to associate each observation or each lesion to one category with an increasing probability of being an HCC or a cancer. Now, I just want to stress that before you apply or you combine the different features, you need to make sure that you can do it. And there is a very important checklist at the beginning corresponding to the fact that you exclude benign lesions or you exclude tumors that are very, very likely to be malignant, but not necessarily HCC. And this is very importantly the LRM for malignancy category, which is something that is new and brought by the LIRAD system. And it corresponds to this presence of a targetoid appearance, where the difference between the center and the periphery is very suggestive of malignancy. It's not specific for HCC, but it's very worrisome. Now, if you do this checklist and your lesion does not fit in one of these boxes, then you can combine the size, the presence of enhancement, and other major features, especially those I discussed previously, the presence of a washout, capsule, and the fact that the tumor is growing over time. And one of the main reasons why this system has been endorsed by the European Association for the Study of the Liver is the fact that most of the time the radiological reports are confusing. They use a variety of terminology and sentences and phrasing that may not be extremely clear as to how much the radiologist feels the lesion is malignant or not. But if we look at the same studies based on the LIRAD category, this is something that really translates way better in terms of communication. So the recent CPG states that the LIRAD system must be used for the non-invasive diagnosis of HCC, and also it reminds the readers of all the features I discussed and how they should be combined. It also stresses that the concept of non-invasive diagnosis should be used, so not all patients should be biopsied, but it also means that they should be used properly, so specifically in patients at high risk of HCC, namely patients with cirrhosis, HBV, and a history of HCC. Patients who do not fall into one of these categories should be biopsied. And that's why, as a side note, the CPG recommend the use of tumor biopsy anytime it is necessary, low-risk patients or atypical imaging presentation. And this system works quite well. We have studies showing that there is an increasing probability of malignancy with increasing categories of risk. And that's also why the guidelines acknowledges that the LIRAD 5 category, which is the high risk of probability, is pretty much equivalent to the previous EASL system, which was a binary one, HCC, not HCC. But the new system provides more categories, especially the one I told you about, LRM, and also a more granular approach of the probability of the tumor. Now, from a radiological point of view, should we favor CT or MRI? Well, recent studies show that there is actually no difference, so the recommendation is you can use both CT and MRI. And if you use an MRI, which kind of contrast agent should you inject? Should it be usual extracellular agents or more recent liver-specific contrast agents? Well, we have now many studies showing that when we want to do a non-invasive diagnosis of HCC, extracellular contrast agents are better than epitheliary ones. for the non-invasive diagnosis. The sensitivity and specificity is a bit higher. These are two results coming from Korea, and we have a similar study coming from France showing that the non-invasive accuracy is better with extracellular contrast agents. So the CPG recommends using extracellular agents as first-line contrast if you use an MRI, but galactotic acid or liver-specific contrast agents may have an interesting role for the local staging of cancer. So if I want to summarize the new recommendation of the EASL CPG based on the LIRAS, this is it. So let me help you navigate through this. You have a new hepatic nodule in a patient. You assess the risk of this patient. The patient is at high risk. You can apply the system. You use a CT, use MRI. If you go to LIRAD 5, it means that HCC is diagnosed. If it's something else, like LIRAD 5 or LIRAD with invasion of the vein, you know it's an HCC or another cancer, so you need to biopsy. And if it's not, if it's something else, one of the lowest categories, ask yourself if the definite diagnosis will change the management of the patient. If so, you should go for a biopsy, and if not, non-invasive diagnosis is probably something you can postpone for a few months. And finally, if the patient is not at high risk, then you need to biopsy. Now, to be fair, there are also people supporting the fact that you should biopsy everybody, because sometimes imaging has downfalls or makes mistakes. It's true, and it's a very interesting debate that we can discuss afterwards if you want. But for now, and sticking to the new CPG of EASL, this is not the case, and imaging is enough if all the non-invasive criteria are present. Now, what I like about this new update of the CPG is also that once you've diagnosed HCC, there is something extra that is proposed by the recommendation, is to look at positive or negative prognostic features. Now, we know them for biopsy, like tumor grade, satellite nodules, or differentiation, and so on. But, and this is very original, the guidelines also suggest that we should look at imaging prognostic features that will help us anticipate whether or not we're talking about a more or less aggressive tumor. And it goes with the fact that actually HCC is a family of tumors with a variety of subtypes. We have 8 subtypes according to the WHO, the non-specific one, but also some other specific subtypes. The most famous one are the macrotrabecular massive subtype or the steatohepatic one, and they have different course of evolution. They have different prognostic, and aside from these morphological classifications, we have more and more data about the molecular background of HCC, and we know now that there are different subgroups of tumors from a genetic point of view. Some of them are associated with a lot of tumors of mutations and are very, very proliferative, and this is the upper groups. And here you have the less proliferative tumors with the less mutations, so they have very different behavior. Now, very interestingly, more and more studies suggest that we can extract from imaging some features that will help us anticipate if we are in the proliferative subgroup or not. For instance, I mentioned the targetoid appearance, so anytime you see a difference between the center and the periphery on arterial phase, on diffusion phase, on hepatobiliary phase, and so on, and this is something that is clearly bears a very strong prognostic value, and we have studies showing that the outcome of patients with HCC very different according to the LIRAS category, and especially between LIRAD M and non-LIRAD M. Aside from this targetoid appearance, other features are associated with the more aggressive behavior, so infiltration of the tumor, the fact that the tumor contains necrosis or large areas of ischemia, or if there is a marked hypersignal intensity on diffusion-weighted imaging. And our group, for instance, showed that in patients with HCC, and even if you adjust for the pathological features, you can show that the tumors would display at least one of these poor prognostic features as a worse prognosis, And what's interesting is that it's very complementary to pathology. So both pathology and radiology provide complementary information. Other features you may look is everything around the tumor, so the capsule, the peripheral anomaly, peripheral enhancement, hypointensity on hepatobiliary phase, which tells you something about the local invasiveness of the tumor around. And also, and finally, we also have some favorable the fact that the tumor contains fats, as I suggested at the beginning of the presentation, or a continuous capsule that has not been disrupted, or the fact that the tumor is still iso to hyper on hepatobiliary phase, because it means that it can still uptake some of the contrast and is not, the hepatocytes are still showing some expression of the transporters, so the hepatocellular function is not completely dead. So my last slide would be that we are moving from a purely diagnostic to a prognostic value of imaging with the progressive building of a radio pathomolecular correlation with the aim at identifying tumor phenotypes that harbor some very different behavior from the low proliferative to the more proliferative subtypes. And I thank you very much for your time and attention, and I will be very happy to exchange with you at the end of this session.